Welcome to our second in this little series of acute gynaecology, mostly focusing on out of hours urgent gynae, but perhaps some things you might be seeing in surgery as well. And this follows on from session 1, which some of you attended last week and which will probably appear on YouTube at some point, but this is being done for those of you in ST3 who really wanted to hear the second part of the session and didn't make it. So moving on, you know who I am, so I shouldn't really have to introduce myself. This is here really to say I'm just a GP. I also happen to be a woman, but I really take affront at the idea that the possession of a uterus is not mandatory to understand and practice some simple gynaecology. So this is all straightforward stuff. I would expect anybody to be able to do this by the end of their GP training, and most of you to be able to do this during your GP training. This is not hard medicine, and I really hope that this is going to give you some confidence to be able to do it. So we've got some aims. So we're thinking about acute gynae problems that tend to come to out of hours. I want you to be more confident. I want you to feel able to assess them. I want you to be able to triage them, think about which ones need seeing, which ones need some care, which can be signposted elsewhere, and to improve the management of your patients with some acute gynecological problems in out of hours. So today we're going to talk about emergency contraception, complications following termination of pregnancy and perhaps and miscarriage, some acute period problems and other acute PV bleeds. So moving on, emergency contraception. Really important to think of emergency contraception as an important encounter with a patient. They're really frequently regarded as a bit like a pill check. Quick, catch up slot, yeah, I can do this. Quick, pill, go and have a cup of tea. We know about 7% of women in the UK of childbearing age have used EC in the past 12 months. And a request for emergency contraception really needs to be a signal that their contraceptive and sexual health needs are not being met. And this is a huge opportunity to give some good health advice and change the future. So we need to assess pregnancy risk. We need to talk to them about which of the 3 emergency contraceptive options are most appropriate and effective. And we need to make sure we are following up-to-date guidelines. So the FSRH produced some really good emergency contraception guidelines in 2017. If you haven't read them, I really would set yourself a PGP objective to go away and look this up later. So have a think. What are the options for emergency contraception? I told you on the previous slide there are 3. Have a think. What are they? Okie doke, so 3 types. So you've got your levonorgestrel pill, which is what people often think of as the morning after pill. There's ELA1, which is ulipristal acetate, and there are copper IUCDs, 3 types of EC. Another thought for you. Which is the first choice for the majority of women and why? Okay, so having a think, thinking about where we're going to go, we're going to move on and have a think about a case study. So it's Sunday afternoon and you are at out of hours doing clinician advice. Kelly, 28, has rung 111 to ask for the morning after pill, and you pick up the phone to ring her. Perhaps actually in these COVID times it's Monday morning in the surgery and she's the next one on your list. Either way, she's phoned up, it's possibly a phone consultation. What are you going to cover? So I just want you to have a think, grab your little pen and paper, make some notes. What do you need to cover in this history? Okie dokes. So, things you need to cover. When did it happen? How long ago did she have unprotected sex? Where is she in her cycle? When was her period? Her last period. Was it a normal period? Is her cycle regular and predictable? How many other episodes of unprotected sex have there been this cycle? Really important to think about, was this a consensual sexual encounter? Do you need to consider some input from the police or from the sexual assault referral centre? Is she at risk of an STI? Was it a regular partner? Again, because we're thinking about STI risk. What contraception, if any, does she normally use? Has she got a preference? She said to you, I want the morning after pill. What does she mean when she says the morning after pill? What's there? What's her weight? What's her BMI? And what plans has she got for ongoing contraception? There's quite a lot there, isn't there? So you might really want to think about this. Is this something as a quality improvement project that you could set up a template for on your computer system? Is this something that you could set up an auto consult for? That might help, mightn't it? So back to Kelly. She had sex Friday night, 2 a.m. She was drunk. The sex was with her boyfriend of 2 years and was consensual. He told her this morning that he thinks the condom might have split. She wouldn't normally be bothered because she takes the Cerazette POP, but she went away with work and forgot to take her pills with her. And she's definitely missed 4 pills, but took one on Friday and one on Saturday. Remember, it's Sunday now. She doesn't usually have pills with the Cerazette, so she has no idea when her last period was. And she's normally pretty careful because they use condoms and the pill, so a double Dutch regimen, so she's pretty embarrassed that this has happened. So, what is the best emergency contraception for Kelly? It's the copper coil. So for almost every scenario, the copper IUCD is almost inevitably the first line option. So it's the only method that's going to work if somebody has already ovulated. So the other methods, the pills, all work by postponing ovulation. So if she's already ovulated, you are too late to use pills. Copper IUCD is unaffected by body weight. It's unaffected by enzyme-inducing drugs. You can leave it in. Ongoing contraception for, well, up to 10 years. If you fit somebody a copper coil and you fit them a T-safe. Failure rate is 0.09%, so really, really low. And you can cover multiple episodes of unprotected sex provided you're early enough on in the cycle. So you can fit any copper IUD. The gold standard is a T-safe CU380A. So you cannot use a Mirena IUS. So it's really important. It's got to be a copper coil. And you can fit it any time up to 5 days after the earliest possible ovulation in a cycle. So when people are going on about day 19, we are talking about 28-day cycles. If she's got a shorter cycle, it's not day 19. We can cover several episodes of unprotected sex, provided it's not yet day 19. And if she's had unprotected sex after day 19, but that's the only episode of unprotected sex, you could still fit one. So the FSRH have a flowchart if for some reason you can't have a copper coil. And remember that actually Sexual Health at Wheatbridge do have key performance indicators for the fitting of urgent coils. So there really is no reason why, even if you don't have a coil fitter in your practice, somebody can't get one. So thinking, when was the unprotected sex? If it was less than 96 hours ago, and we think low risk, more than 5 days before ovulation, and they're slim, you could give levonorgestrel. If they're high risk, so it's less than 5 days before ovulation, or it was more than 96 hours ago, you give ulipristal. But you've got to remember with ulipristal, if they've had progestogen in the last week, it's not going to work. So ulipristal is a progestogen antagonist. That means it affects progestogen, but progestogen affects it. Remember, Kelly can't have ulipristal because she took her pills Friday and Saturday. She just hadn't taken them when she was away with work the week before. It is affected by enzyme inducers, and asthmatics on oral steroids can have all sorts of problems because it can make steroids less effective. So that's just worth thinking about with your ulipristal. So if we're going to compare them both, so remember, they both work by delaying ovulation. If you've already ovulated, oral EC will not work. So Ella1 is going to be second line to the copper coil in the majority of situations. We've got those interactions. If you've had progestogen within 5 days, it won't work. You can't quick start a POP or a depot or a combined pill. You can't have it if you're on oral steroids. And if you are breastfeeding, you need to pump and dump for a week after taking Ella1. So levonorgestrel, if the risk of pregnancy is low, single dose, can and should always quick start some alternative contraception and then use condoms till the next period with a pregnancy test 3 weeks after if they haven't had a normal period. If they're on an enzyme inducer and they don't want a coil, it's unlicensed, but it's the next best option because you definitely can't use ulipristal, but levonorgestrel may well be affected. Okie doke, something completely different. So just thinking about post-TOP complications, because they do still sometimes present to us and they can't necessarily get hold of the unit at the hospital. So it's just worth us just being a little bit aware about what's normal, what's not normal. So main things people tend to present with are pain, bleeding, infection and psychological sequelae. I'm just going to revise options for early termination of pregnancy because I think it's really worth knowing, and particularly now our patients are self-referring in for terminations, we might not know that actually they've been or anything's happened. So early medical, they get mifepristone, which is an antiprogestogen, orally, and then 48 hours they have some PV misoprostol. Recent changes to the law means they can then go home and complete their TOP, miscarry at home, if they're under 10 weeks. So that's perhaps where they might end up ringing, actually in a bit of a panic. It's all got a bit worse than they were expecting. They can't get through to the Women's Health Unit. So the medical TOP, after they have had their PV misoprostol, they usually will start bleeding about 4 to 6 hours later. It's not uncommon to get nausea, vomiting, abdo pain and diarrhoea. So those things are reasonably common. Get a call from a relative, my daughter had the termination, but she's now got terrible, terrible diarrhoea and she feels really, really sick. Don't know what to do. She's going through this bleeding and she feels really sick. It's probably the drugs and it's probably normal. So surgical TOP under GA is a day case thing. They need the usual post-GA advice. And just worth a reminder that local anaesthetic TOP can work really well for a lot of women. So you can have up to 9 weeks. It's very quick. They're wide awake. You get minimal bleeding, home same day. So the bleeding after a TOP is essentially the same as after a miscarriage. So while they're passing products, it can be really heavy and they may well bleed for a good few days after. They mustn't use tampons. That's really, really important. Cervix is still open. Tampon may go up, either get lost in the uterine cavity or increase risk of infection. And they shouldn't have sex until the lochia has settled and the cervix is closed. They are, however, at risk of pregnancy almost immediately. And a little bit after a miscarriage, often people's fertility is actually higher after a failed pregnancy than it was in the first place. Okay, moving on, period problems. So just acute period things. So acute menorrhagia, acute dysmenorrhea. So just remembering menorrhagia, heavy periods, it's essentially a subjective definition. Think about causes. Most of them are idiopathic. Fibroids, endometriosis, bleeding disorders can make things worse. So just thinking about acute treatments, tranexamic acid can work really, really well. It's contraindicated. They've got family history of DVTs though, so don't forget that. You can use NSAIDs as well. Now this always feels a bit counterintuitive. Don't non-steroidals make you bleed? Weirdly, no. They don't make you bleed vaginally. They can upset your stomach lining, they can make you more likely to have an upper GI bleed, but because of their effects on prostaglandins in the endometrial lining, actually they reduce bleeding. But we don't use mefenamic acid anymore, we use ibuprofen or naproxen. Longer term, thinking about management, IUS is your first line really, but you might want to use a combined pill, cyclical progesterone, endometrial ablation, and hysterectomy is rarely the solution. So those people who come and say, take it all away, my periods are so heavy, I need a hysterectomy, just worth thinking, they're probably not going to get that. Don't forget new menorrhagia in someone over 40, especially if they're obese, needs investigating for endometrial hyperplasia, because you don't want to miss hyperplasia or worse still, a cancer. A little bit about dysmen, painful periods. So you're going to think about, is it primary or secondary? And remembering primary dysmen is really common. It's also incredibly, incredibly disabling and horrible. Secondary, if you think somebody's got secondary dysmen, you really want to be starting to think about things like PID, adhesions and endometriosis. So if you think about acute management, analgesia, NSAIDs, self-care, hot water bottles, hot baths and massage. But don't forget a miscarriage or an ectopic. Oh, I'm having my period and it's the worst pain I've ever had. Is this when you were expecting to get your period? Is it late? Is there any chance you could be pregnant? Because actually they may well be presenting with what they think is a really painful period, which is actually bleeding in pregnancy and needs different management. Longer term, we're going to be thinking about cycle manipulation, so usually thinking about the combined pill or considering any contraceptive method that might actually induce amenorrhea. Okay, so more bleeding things, postcoital bleeding. So taking a good history is really, really important. Don't forget trauma. If somebody's got a vaginal cervical laceration, they can bleed profusely. So if they are bleeding phenomenally heavily after intercourse, perhaps asking who they've had intercourse, what has been inserted into their vagina. Sex with a man with piercings in his penis can cause quite a lot of trauma, or inserting objects into the vagina, they can bleed really, really profusely and need urgent gynae review. You can lose 2, 3, 4 litres of blood from a vaginal laceration. Don't forget infection, so cervicitis, particularly from chlamydia and PID. Ectropions, classically in pregnancy or people on the pill, They can bleed quite a lot after pregnancy. Don't forget your cervical cancer. So they're all going to need investigation. If they're hemodynamically stable, probably want to bring them in routinely, have a look at their cervix. What's going on? Do they need some swabs? Might they need a referral? So just a few little pictures. So ectropions, usually estrogen driven. They're really common in women on the pill. Very, very common in pregnancy. And generally we just reassure them. But you can refer for cautery if they're really, really problematic. So you can see here that kind of redness is quite symmetrical. And essentially what you've got is the transition zone, which is the bit that comes out of the cervix that you're sampling when you do a smear, has spread out onto the front face of the cervix. Compare that with cervicitis, which just looks horrible, doesn't it? Lots and lots of inflammation, discharge, bleeding. So that's what chlamydial cervicitis looks like. Pretty horrible and something you really don't want to be missing. Postmenopausal bleeding. Okay, so this is always abnormal but rarely an emergency. So you do need to take a good history. Most of them will be hemodynamically stable, but make sure they're not, pouring with blood. And then they do need investigating. We're really lucky at Chesterfield. We've got a PMB pathway, so they will have a TV ultrasound, and if the endometrial thickness is normal, they get discharged back to us, and if it's abnormal, they immediately get sent for a 2-week wait hysteroscopy. So it's a really, really good service and absolutely worth knowing about. The form does have something on it on ICE about whether you've examined them or not. I think use your own judgment as to whether you can manage to do a speculum or not. It does help though, because actually if you see an enormous mass arising from the cervix or something huge in the vagina, you're probably going to go for the 2-week wait rather than the PMB ultrasound. So just think about causes. So really think about endometrial cancer. It's associated with obesity and type 2 diabetes. Tamoxifen increases your risk quite dramatically. And this is why we use progestogens with HRT. So the estrogen would proliferate the endometrium, so we use the progestogen to keep it thin. Just worth also thinking about atrophic vaginitis, vulval atrophy, and genitourinary syndrome of menopause, because they can sometimes bleed as well, though they'll tend to bleed from little cracks and fissures on the outside. And just thinking about infection, don't forget the STIs are women's in their 50s who don't need contraception, get a new partner, don't think about STIs, know they don't need contraception, don't use condoms, and then get an infection. A little bit here about this genitourinary syndrome of menopause, which is hopefully revision for most of you. So it affects about half of women after the menopause. Just worth thinking, menopausal vasomotor symptoms get better with time. This doesn't. This gets worse and worse and worse. Dry vagina, painful sex, postcoital bleeding, itching, soreness, burning, recurrent frequency, urgency, perhaps recurrent UTIs, and some stress incontinence. So it's caused by loss of estrogen. So you get thin vulvovaginal skin, you get a loss of the periurethral fat pad, so they get frequency, urgency, their urethral opening is a little bit wider, more patulous, you get more risk of UTIs because it's more open, they struggle with incontinence for similar reasons. So topical estrogen is the answer, pessary gel or a vaginal ring. If they've still got a uterus, after daily use to get things under control, you need only to use it a couple of times a week because there is a risk of endometrial hyperplasia. And if they get any PV bleeding, they need to come and tell you. But if they need HRT for their vasomotor symptoms, that'll probably help with their genitourinary symptoms as well, though you can use the two together. NICE doesn't really make any statements about vaginal lubricants or moisturisers, but actually there is some evidence that those can help as well. So finally, a little bit of further reading for you. So go and have a look at that FSRH guideline on emergency contraception. It's brilliant. NICE CKS have a really good summary of menorrhagia, or there are the full-on NICE guidelines from 2018 on heavy menstrual bleeding, or there's the NICE NG23 menopause guideline, which is really helpful as well, particularly thinking about the vaginal atrophy side of things. Thank you very much for listening.